This is LiveWell Talk on COVID-19 and respiratory therapy. I'm Dr. Dustin Arnold, Chief Medical Officer at Unity Point, St. Luke's Hospital, and I'm joined today by the manager of the Respiratory Therapy Department, Julie Smith. Welcome.
Thank you for having me today.
What is respiratory therapy?
So respiratory therapy is all about taking care of patients' lungs.
Okay.
So the ins and outs, diagnosis, treatment, therapy, education with patients.
You know, I think people easily call to mind what a doctor does and a surgeon and a nurse, but, I don't think they think about respiratory therapy, even though that is an integral part to the delivery of care in the hospital. It's a huge contribution, even more so with the COVID-19 infections, which it may cause. Now, today's podcast is going to be a little inside baseball and more intended to discuss respiratory therapy and how it fits in and how the staff is going to adjust and facilitate excellent care as they always do during this pandemic. But I think the general public will also learn some information from this in regards to the role of respiratory therapy and the decisions that need to be made. Julie, one of our first things that we talk about is, in our guiding principles, is to protect our patients, our staff, and our physicians.
Right.
What measures are you taking, for example, for the aerosol generating procedures, the nebulizer therapy, the intubation, the extubation that generates aerosols? Even though COVID-19 is not airborne transmitted, we think that it may become airborne when there is a procedure like that. So what does your team do to prevent transmission?
Right. Well, the team is making sure that we're putting filters in place wherever we can on exhalation valves, on our BiPAP, CPAP, ventilators, and even so the nebulizers have a filter that we can put in place as well. We're also ensuring that we're wearing the proper PPE. So if we're doing an aerosol generating procedure, you really need to wear your N95 goggles and face shield, or you're wearing your Max Air.
So it's considered airborne precautions rather than just simply droplet.
Correct.
Or contact.
Yep.
This has been, as I've said, that this is like building an airplane as you're flying it, right?
Mm-hmm.
And, we had data coming out of China, whether you can trust it or not, that's for another podcast. Then you had Italy, which I learned this week reading in JAMA, they're starting to bring out the data from Italy. And it's interesting that they were at 87% capacity in their ICU when they got their first patient of COVID-19. So they were already at capacity for their winter months. They had no opportunity, like we've done, to postpone elective surgeries, save personal protective equipment, PPE, like you mentioned. But one of the things that came out early is we shouldn't use high flow oxygen. We shouldn't use BiPAP. We shouldn't use CPAP. We should just go straight to intubation. And that kind of goes against kind of the normal operating paradigms. Mm-hmm. And I know some of the staff, we were working on that assumption and we've changed that. Tell us, how does vapotherm or high flow oxygen fit into the treatment of these patients at this time?
Yeah. Well, this is a rapidly evolving situation, and we have to find out what's working, what's not working, and how we can improve outcomes. So one of the things is that we're looking at is high flow oxygen. We've got to find that bridge for these patients so that we don't put them on ventilators right away, because we will run out of ventilators if we do that with each and every patient. So we really want to do, what we really want to do is our best to use all of our resources and keep those patients off of ventilators. So, and you're right, the newer literature, Society of Critical Care Medicine, is suggesting that we should consider putting these patients on high flow therapy. So at St. Luke's, we have vapotherm, so it can deliver up to 40 liters of warm, humidified O2 to the lungs. It's a higher velocity of flow that allows the upper airways to fill up with oxygen, creating a reservoir. So this can help reduce the patient's work of breathing and then increases the oxygenation that the patients can get, because with COVID-19, that seems to be, the biggest issue is these patients can't oxygenate.
It's an oxygenation problem, isn't it?
Absolutely.
I think the paradigm in place now is to use the BiPAP as a bridge to see if you can prevent them from going on the ventilator. Yeah. And if you have to, you have to. And if you can avoid it, wonderful. When I practiced critical care medicine, that was the way we looked at BiPAP. Now I know your team and the pulmonologist will put someone on BiPAP for days. Where my rule is 6 hours, and if they couldn't turn around that time, they either turned around or they went on a ventilator. Mm-hmm. And so I think we kind of gone back to that way. So it does show you that if you just keep doing what you're doing your entire medical career, sooner or later you're going to be cutting edge, because it just kind of comes back as a pendulum swings. So I'm feeling pretty good about myself these days from that standpoint. When they do go on the ventilator, particularly they're on it a long time, aren't they?
They really are. That's what we're seeing right
Yeah.
now. It's hard to get them off. So I think if we can prevent them from going on the ventilator in the first place, it's the right thing to do for these patients, because the long-term usage on a ventilator can really cause more lung injury.
In one of the editorials for the Society of Critical Care Medicine that came out, Saturday last week, really said, the younger patient, the 40 to 50-year-old that relatively healthy, has good lungs at baseline, that you should give them a trial vapotherm and BiPAP, because they have a good chance to avoid being on the ventilator.
Absolutely, yep.
Now, we do have plenty of ventilators. I talked to you about that, the
Yeah.
number all the time. I feel comfortable with that. But one of the things that has come out of the literature, and you even hear it on presidential press conferences, about converting anesthesia machines to ventilators. It's not that easy, is it?
No, it's not.
It's not just a plug and play.
No,
right?
It's very difficult.
Yeah. And it would require an attendant, because your team is not familiar with an anesthesia machine, correct?
Correct.
Yeah,
correct.
so you
It's very
would
different.
require an anesthesiologist or an anesthesiology nurse anesthetist to be there to make sure that machine's running
Right.
appropriately, because it was never intended to be a long, 24 hours a day on, those machines.
Absolutely right.
Now, the protective ventilation strategy, that's not something new to COVID, but it is something that we do more than we used to for other conditions, but certainly with this type of decreased oxygen level that patients with COVID had. Tell us what sort of tidal volumes or size of breaths that we're giving patients.
Yeah, well, we want to make sure that those tidal volumes are lower tidal volumes, because the lungs with this COVID-19 already have a little bit of injury induced with them. So we want to prevent any more injury. So lower tidal volumes is what we want to do. The ARDS-NET protocol, the 4 to 6 milliliters per kilogram.
And then if they're on the ventilator, is it airborne or droplet at that time? Precautions.
If on the ventilator, you are going to be in droplet precaution as long as the system is a closed system and you have your filters in place.
Okay. And so if it would pop off, it's less than 2 minutes, so your chance of exposure is pretty small.
Exactly.
And we're trying to use as many negative pressure rooms as we can. I mean, that's a luxury that we have plenty of now, but we might not, and just have to make do. They're doing something unusual that they don't do all the time, and it's not easy to do, but they're proning the patient or laying the patient on their stomach. What's the idea behind that?
Oh yeah, that's a great question. So yeah, it's another early intervention that we can do. We place patients on their stomachs while they're being on the ventilator. We've done this before.
Right.
Yeah, but it's really working with these patients.
Yeah.
So we're finding that doing this early in the disease process is benefiting them. Not only are we doing this with patients on the vent, we have actually asked some of our patients on vapotherm high flow therapy to actually lie on their stomach as well, and we've seen great benefit.
Because what that does is it allows the blood going to the lung and the oxygen going into the lung to have a better match, correct?
It does, and it allows, the heart ends up resting on the sternum when the patients are in prone position, and that allows the bases of those lungs to have better aeration and oxygenation.
Interesting. Not easy to do, though. I mean, it's not, there's a lot of logistics to flipping that patient on their stomach in the ICU for an extended period of time, isn't it?
You are correct. It's a lot of manpower.
Yeah.
And then we have a protocol in place that once they are prone, we leave them prone position for 14 to 16 hours.
And then back to the...
And then they go back to their back, supine.
So now, what are some of the complications then? I imagine you're setting the patient up maybe for a pressure injury, pressure ulcer, because they're positioning them different.
Could be. One of the things that we do for the ET tube is we change the tube holder out, so we make sure that we put pillows in place, and we're looking for all of those pressure points to try to relieve those pressure points.
Yeah, because 12 hours is certainly long enough to develop a pressure ulcer, 90 minutes in some studies if a patient's sick.
Yeah.
Now, positive index expiratory pressure, or PEEP, how is that fitting into the COVID patient?
Yeah, well, these patients, they go into adult respiratory distress syndrome. And in that disease process, your alveoli are very inflamed. So the alveoli really like to have that PEEP. That's kind of where the magic occurs, the oxygenation and ventilation in the lungs. So PEEP can really help with that. So higher PEEP levels is what we're seeing with these patients.
And what's the high that you're seeing?
12.
12.
Starting out at 12. Normal PEEP, that when we put a patient on a ventilator, we use 5.
Yeah.
So we're above doubling it, that PEEP pressure.
When I trained, this is obviously the early 90s, you know, you would get scolded if you have someone on 10.
Mm-hmm.
You know, your attending would call you out and say, what are you doing? You know, now I know there's trauma surgeons that use 20, you know, just like it's nothing, which really, that blows my mind. Now, I know sometimes we've used nitric oxide in the past for patients, which is just helps dilate the capillaries in the lung and better air exchange.
Mm-hmm.
Do you see that this being a role in this particular patient category?
I really don't think so. I think that if we do see a role, it'll be minimal. You know, it's going to be that patient that has been on the ventilator for a long time, the patient that we have put in prone positioning for a long time, and we're just not seeing improvement.
So after you've maximized everything you can do, you're going to just, why not try it, right?
Right.
It's not going to hurt, so let's try it. How about, I know your team, and particularly Andy, has done a lot of legwork with ECMO therapy, and they're so excited about it. How do you see ECMO? It's kind of similar to kind of after you've maximized everything, then? Yeah,
that's what we're seeing. On the ELSO website, we've been following the numbers, and I looked this morning, and in North America, we've got 148 patients on ECMO that are COVID positive.
Wow.
So not very many.
No, not when you consider the number of cases. I mean, that's
exactly.
Pretty small.
Yeah.
Which either means we've doing a good job of oxygenating or not using ECMO enough. You know, well, that'll be seen. You know, it'll be interesting when this is all over with, and we look back at all the data and find out what we really knew and what we didn't know and what works and what didn't. I mean, I think we're close on a lot of these issues, but definitely some of it will change.
Absolutely. It is an ever-changing situation. We've never been in this before, so.
Yeah, I said the other day, you can just make up stuff because you're no more right or wrong than the next guy because it changes so rapidly.
Exactly.
You know, Julie, one last question. Why did you become a respiratory therapist?
Oh, well, my mom actually was a nurse, and she told me to go into the healthcare field. There would always be a job in healthcare, a need. So I wasn't really too keen on being a nurse. I was trying to find my way, and I happened to stumble across a video about respiratory therapists and fell in love with it. I've been a respiratory therapist for 28 years now, and here at St. Luke's for 25, and I wouldn't do anything else.
So you started at St. Luke's when you were 6?
Right.
Okay, all right, excellent. Julie, thanks for taking the time out of your busy schedule. You and your team are so busy and so important right now to this effort, but I think this is important to discuss on this. Some of it was inside baseball, a little shop talk, but I think the general public may have at least come to appreciate how the respiratory therapist factors into the team, perhaps an appreciation that was unrecognized previously. Once again, that was Julie Smith, Manager of Respiratory Therapy at St. Luke's Hospital. For the most up-to-date information on COVID-19, visit our website at unionpoint.org or the Centers for Disease Control and Prevention website at cdc.gov. If you have a topic you'd like to suggest for the COVID-19 pandemic, please shoot us an email at stlukescr@unionpoint.org. In the meantime, wash your hands, cover your cough, and confine yourself if you're ill, and practice social distancing.